suspend being an anaesthetist for a few minutes and think, as an obstetrician might think, because you can notice the title of this is Obstetric Emergencies, not Obstetric Anesthesia Emergencies. And if we look at a paper from the United States, from an Obstetric and Gynecology journal of a few years ago, where they reviewed deaths in a single state, they found that 40% of these maternal deaths could have been prevented. Almost all of the deaths from hemorrhage and chronic disease could have been prevented. And they felt that those amniotic fluid embolism and cardiovascular accidents were not always considered preventable. Now, as we know in the United Kingdom, it is mandatory for us to report maternal deaths, and every 3 years these deaths are published in a book. This is the latest book published last year, and it covered the deaths between 2006 and 2008. And look, commonest cause of maternal death in England, cardiac disease, i.e. a preventable condition. If we had better management, arguably, many of these deaths may have been preventable, as per the suggestion in the United States paper. But of course, look at what's happening. And I want to look at a very common emergency on the labour ward, one that you might not consider an emergency, but that very often is. As our last speaker says, we have an epidemic of caesarean sections. When the Queen came to the throne in 1952, the caesarean section rate in England was less than 5%. So 60 years ago, less than 5%. Now, we're not quite at the 33% of the United States, but we certainly are somewhere between 25 and 30%. Then, when you break down caesarean sections, the vast majority of them are emergencies. So 66% of all caesarean sections we do are emergencies. Now, quite patently, this is the wrong word. They are not all emergencies. And some years ago, the College of ONG and Anaesthetists in the UK decided to try and categorise these sections into degrees of urgency. And we had category 1, 2, 3, and 4, as you can see. And 4 is an elective section. The others then have varying degrees of emergencies, and I'll come to that now. Now, you're anaesthetists. Obstetric anaesthetists, you're very good, you're used to emergencies. You can do many things at the same time. This is your obstetric colleague. He's a much more limited individual. His mind is on one thing, and it's a very important thing. Can he get this baby delivered as safely as possible without getting himself into too much trouble? And he depends on you. Because if you look in countries like the United States and the United Kingdom, and probably here too now, I would suspect, medical legal issues are a very big push in many of these emergencies. And if you look at the claims, the medical legal claims in the United Kingdom, and see that between 2009 and 2010, nearly £1 billion was spent on medical legal claims. That's £1 billion that's handed over in medical legal claims, and that isn't then spent on medicine. It's going to the lawyers. And half of these claims are obstetrics. Hence why the obstetrician is so keen on proper categorization of emergencies. So what we're really interested in is the category 1. That is a baby that must be born as quickly as possible when he says it's an emergency. Category 2, you've got about 30 minutes. Category 3, at a maximum, you have 75 minutes. So let's concentrate on category 1 and what that emergency means to you, me, and the obstetrician. Because fetal distress, unfortunately, can end up in an intrapartum death. And they're not uncommon. And even in a so-called sophisticated European country, about nearly 1 in 1,000 babies can die from intrapartum and peripartum events. Now, if you add all of that up, that's like a plane leaving Heathrow every month and crashing. What will we do about it? And 50% of these deaths are avoided. So what can you do to try and minimize fetal morbidity? Now, there are all kinds of causes of fetal distress, of which very common is that the placenta itself is insufficient, the cord is being compressed, or it prolapses, or you have shoulder dystocia. The baby actually gets stuck in the process of delivery. All of which you very much play a potentially big role. Now, how do we detect placental insufficiency? Has your mother got a beautiful, healthy placenta like this, or is this placenta absolutely dying with severe consequences for the baby? And you need to be able to assess mothers and babies almost like an obstetrician. Good obstetric anaesthetists know a lot about obstetrics. What's happening to the baby in utero when everything is starting to be a little bit insufficient? Well, the fetus will always protect its brain. There's preferential shunting of blood to the head to protect the fetal brain. And gradually, of course, the fetus becomes hypoxic. But we have no way of assessing the fetal brain in utero. And so what do? We look at the CTG, like an ECG. Not terribly helpful, because by the time your CTG is abnormal, that baby is probably, though not always, seriously compromised. And so I would put it to you that I would expect all of you to be almost as good as your obstetric colleagues at reading the CTG. And you've got to ask, why is it being done? And if it isn't necessary to record the CTG, please don't do it, because it has a low predictive value of neonatal outcome. And arguably, I would put it to you that it is responsible, almost single-handedly, for this ridiculous rise in the cesarean section rate that we do nowadays. You and I don't use an ECG as a predictive outcome in adult anesthesia, but here we're using it in obstetrics. But read it you must be able to do. And I briefly commend you, and you probably all use it, the mnemonic of Dr. C. Bravado, where you define the risk, you see the contractions. I don't want to go into this too much in this talk, but the most important things for you to read on the CTG are the baseline rate, somewhere between 110 and 160, how variable is it, and how many accelerations. Read this, know how to read it. What else are we looking at? Well, we look at the LIPOR and meconium. Meconium is not very predictive, and it's only predictive if it's very green, grade 3, in conjunction with a bad CTG. And what about the fetal blood sample? When you see that obstetrician going in and out of the room, sampling the fetal scalp, you know that there's about a 70% likelihood that that lady is going to have a cesarean section in the next 2 hours. And remember, this is a very much more important monitor of the fetus than the CTG, because the predictor for adverse neonatal outcomes is a pH of less than 7 and a base deficit of greater than -12. And of course, I'm sure in Romania, as in England, that once that core pH, not core pH, I should say scalp pH, goes below 7.2, you absolutely must deliver that baby. And of course, you know, you can see variable deceleration, but here's a nasty CTG, a late deceleration with no variability in that CTG, or worse still, a declining fetal heart rate. This baby is in the process of demise. Is there anything you can do to try and improve, resuscitate the baby? I think this is terribly important. Obstetricians are very bad at intrauterine fetal resuscitation. This is where you must come into your own. And there's the world spoiled. Stop the oxytocin if it's running. Put the mother in the lateral position. How often do you see mothers lying on their backs with the obstetrician trying to do a vaginal examination, yet the CTG is very suboptimal? Give the mother oxygen, increase the intravenous fluids, and if she's hypotensive, yes, certainly get that mean blood pressure back to a reasonable rate. And if she's hyperstimulating, tocolysis, either subcutaneous salbutamol, although you may not find that quickly, but we always keep spray glycerol trinitrate on our machine in theatre, so you can give the mother 2 puffs of sublingual GTN to try and control those contractions. Simple, easy measures that you understand very well, but that the obstetricians aren't quite as good as you at. And when you get into that operating theatre, put on the maternal pulse oximeter and put on the CTG, because please do not misinterpret a maternal tachycardia for fetal well-being. Because if you tell a mother, oh, let's go to theatre, your baby is dying, she's going to get a tachycardia. Don't muddle the two, put them on. And very often you find, when you get to the operating theatre, if you have been doing good intrauterine fetal resuscitation, if it's been successful, you may obviate the need to do an emergency cesarean section. And I would reckon in our own unit happens between 10-15% of the time. That you go to theatre, the baby's better, and you go back to the room. Very, very important part for you. Then, of course, there is the absolute emergency, umbilical cord prolapse. These are the associated factors, probably well known to all of you: unstable lives, multiple pregnancies, polyhydramnios. You know, the mother with a high presenting part with polyhydramnios, the membranes ruptures, the cord comes down ahead of the baby. And of course, the fetus is vitally cutting off his own blood supply. And the solution is to push the baby's head off the cord. Now, you will find when you're called to this room, the mother will be in the bed, the obstetrician will be in the bed, and he'll be trying to push the cord off. And, you know, people behave very badly in this situation. There's too much rush, too much panic, and we often do bad anesthesia. Keep calm in this situation. Because if the obstetrician has kept the baby's head off the cord, that baby will be fine. And I have a colleague who's worked in Africa, and he said they sometimes had 3 ladies waiting for cesarean section with prolapse cord, and they were fine. So don't panic. Stop the cord compression and discuss your anesthetic options with the obstetrician. And that is true in all obstetric emergencies. Because what kind of anesthetic are you going to give in an emergency? Well, undoubtedly, if it's a real emergency, this baby has to be out in under 15 minutes. A general anesthetic is always the fastest. Undoubtedly. Much as I hate general anesthesia in obstetrics, it is the fastest. But I will still try to avoid it. Because if you're a good obstetric anaesthetist, and it's your lucky day, you probably get a spinal in quickly. Unless, of course, this ever problem of obesity is coming, it may not be so easy. But discuss this with obstetrician. He'll know how good you are at your spinal, and he'll say, okay, I'll give you 5 minutes. And that's a reasonable conversation. And what about if your mother has had an epidural in situ? And if it's effective, now, only if it's effective, never, ever, ever top up a dodgy epidural that hasn't been given good analgesia. Top it up. Now, whatever I don't know what your favorite solution is. I have to like ropivacaine. People have different mixtures. I don't want to go into that. But top it up, and remember, I will put it to you, that you can start your surgery on a rising block. You don't have to wait for the block to be okay to let the surgeon start. If it's rising, prove that it's rising, and the mother is happy to let you start, go ahead. But this is probably for the more experienced. And finally, the last big fetal emergency is shoulder dystocia. Again, we've got a mnemonic for everything in England. You probably have similar mnemonics here in Romania. But you'll be called or you're in the room. And of course, you're likely to need to be giving help here for the Mac Roberts maneuver, where the mother is pulled to the end of the bed, her legs are flexed up and abducted on her abdomen. And somebody will say to you, can you exert downward pressure on the shoulders of the fetus to get that under the pelvis? Know how to do it. Because the bad thing is, if it all fails, how many of you have ever been involved in a Zavanelli? Completely unpleasant. That means you push the baby back inside and do an emergency section. This really traumatizes people. It's horrible, and you've got to be good anesthesia, but also help the obstetrician. It's important to have accurate record keeping for shoulder dystocia. You have a lot of damaged babies, and it's very rarely death, it's often cerebral palsy. So you need very careful timekeeping, because this often ends up in the course. And I must say, we now have regular fire drill scenarios for shoulder dystocia in the same way as we do for obstetric hemorrhage. Right, I now want to move away from those emergencies involving the fetus, probably they are the most important, and the important thing is to categorize your cesarean sections correctly. I'm not going to spend too much time on hemorrhage because I know there are other talks coming on hemorrhage. I just want to stress the emergency aspects of hemorrhage rather than too many other things. And I want you to look at obstetric hemorrhage in 2 ways. Because very often we know we are expecting to bleed. Or it's the other one, where it's completely out of the blue and you're called to a room and blood is all over the floor. Separate these 2 in your minds and have 2 different plans for the planned and unexpected obstetric hemorrhage. Look, you know that if there's abnormal placentation, accreta, percreta, increta, or a placental accreta, you know before you start the cesarean section that there's a high likelihood, not 100% likelihood, but a very high likelihood that she's going to bleed. And please be ready. And again, another bad thing about the epidemic of cesarean sections is look at what it does to the incidence of abnormal placentation. Okay, 1 or 2 cesarean sections are fine. But if you're planning on having 4 babies, you should be aware of the high risk, the 10 times higher risk of abnormal placentation with your 3rd, 4th, 5th cesarean section. And of course this in hemorrhage is what we're trying to avoid, and now the Royal College of Obstetricians are very keen that we salvage the blood, and we have now said, this is a green top guideline from the College of Obstetricians, and I recommend these green top guidelines on the website of the Royal College of Obstetricians in the UK. They're absolutely fantastic. But they say you should set up cell salvage for any case where you think you're going to lose more than 1,500 ml of blood. That means in most obstetric units, such as my own, we have a cell salvage machine in the operating theatre permanently with staff trained to set it up and use it. Are there any worries about it? Remarkably few. There are only 2 that ever really worried, and one was fetal red cell contamination in the mother with rhesus negative. And yes, it happens, but it can be dealt with. After the bleed is over, do a Klein-Hart test, and if necessary, give her anti-D. So problem solved. And the next one we worried about was iatrogenic amniotic fluid embolism. And this fear has now not been substantiated. And even these 2 here, where we said, have a separate sucker for the amniotic fluid and the blood and use a leukocyte filter, gone. The wash cycle of cell salvage is absolutely fine for getting rid of amniotic fluid. And please don't use the leukocyte filter. It slows down giving back the blood and breaks down products in the blood, the leukotrienes, which are heavily associated with severe hypotension. So please put your expensive leukocyte filters in the bin for obstetrics. And we probably can use it for vaginal bleeding, but there's been no big studies out there, and that's where we need more studies in that area. Don't forget interventional radiology as part of hemorrhage, be it prophylactically by putting sheets in the internal iliac, or you can also embolize if the bleeding becomes excessive. And if your mother is stable, there's no reason why at the average postpartum hemorrhage you can't take her to the interventional radiology, put some French gauge catheters through her femoral arteries, into her uterine arteries, and embolize bleeding points. Do embolize both sides because the collateral circulation in the pelvis is massive. Other factors with respect to emergencies and bleeding is the fact that if you've got a proper ongoing hemorrhage, you're going to get a coagulopathy. Your hemorrhage itself loses you clotting factors, and the fact that you give IV fluids and pack cells without clotting factors gives you a coagulopathy. Be aware of that, and please now, as they would in Afghanistan, replace everything with clotting factors as well as blood. Beware hypothermia and beware acidosis. The lethal triad can be very, very important in obstetrics. Remember, if you're acidotic and your pH goes down, your clotting factors just simply will not work. Similarly, here we have the effect of factor 7A of acidosis. The more you become acidotic, the less you will clot. Similarly, for cold, if you're hypothermic, you cannot boil an egg in cold water. Clotting factors are proteins. They will not work if the mother is cold. They will not work if she's anemic. Remember also hyperfibrinolysis and think tranexamic acid. This is an important component in obstetric hemorrhage. The CRASH trial published in 2010, 20,000 patients randomized to have tranexamic acid or placebo. Big reduction in blood loss with no thrombosis. The woman trial is currently on in Europe and Africa. We don't know the results, but keep an eye on this space. But use it if you need to evaluate the results. In terms of fitting, this is another emergency we'll be called to. If you're called to a woman who's fitting in the labour ward, it's probably eclampsia. Do not rush her to theatre for an emergency cesarean section. Stabilize. ABC. Give her intravenous magnesium over 20 minutes. Get her Maintain her on magnesium at 1 gram an hour. Get her therapeutic levels between 2 and 4, and only reduce the magnesium level if she's got a low urine output. Clinically, this is the important one. If you've got bad preeclampsia with a low urine output, you're giving magnesium. Watch the levels. For urine output is good, you don't have to worry about the magnesium levels. And then go on and stabilize your preeclampsia. And finally, I want to go to cardiac arrest during pregnancy. How many of you have been to a cardiac arrest during pregnancy? The audience, hands up. Okay, our American, well, there's something about America, doesn't it? Where they have these, oh, right, somebody back there. Yes, okay, hands are going up now. The incidence is about 1 in 30,000. So you may not see one in your lifetime, but you should be ready. Again, ABC, relatively simple. Nothing is different to your resuscitation guidelines published by the Resuscitation Council. Getting the circulation going is difficult because of vena cava occlusion. And you need to be inventive about getting that baby off the aorta. Push the uterus to the left or have some kind of device. Think about it. You know, a chair pushed under the mother like this is a very effective tool in getting her onto her side. Pushing it manually to the side is another way of doing it. Getting medical students, getting other members of staff to be solely responsible for this important component. But of course, what you have to do fairly quickly is deliver that baby. And the advice now is very specific. That within 5 minutes of that cardiac arrest, the baby should be out. That means 4 minutes after the arrest is called, you've got to be starting that cesarean section so that baby is delivered. How many of you think now to your local maternity ward? You all have a crash trolley, a resus trolley? Do all of you have a cesarean section pack, a mini pack with a scalpel, blade preloaded? You can't go putting a blade on a scalpel handle in an emergency. Your hands will be shaking. Do you all have this on your trolleys? I checked out about a month ago and it was gone, so we put it back. So make sure you go back and make sure you're ready for that cesarean section. Because of course, by relieving the aortocaudal compression, you will increase the venous return, you get more effective chest compression. You may have to consider it, even if the fetus is non-viable. And there are very big ethical things in here. You may have to think about this gestational age, and although the advice is obviously to adapt the cesarean section, I think most obstetricians would still do a balancing incision. Could you do a cesarean section if you were the only person in the room who was in any way experiencing obstetrics or obstetric anesthesia? And of course, while you're doing that cesarean section, you should still be doing CPR. And as I said, maternal survival correlates with rapid delivery. And of course, the baby is going to be very compromised as well in this situation. Be prepared for neonatal resuscitation as soon as that baby is delivered. Equally, think again to your resuscitation trolley. You all have a bag of infralipid on your resus trolley on your labour ward? I'm sure you have. We certainly do, and we're getting better at this. Because I'm sure you're very well aware that any cardiac arrest secondary to LA toxicity, you would essentially start giving infralipid. I don't think any longer consider it, you would give it. And essentially, this regimen, as I put here, works out in the first instance as giving almost the whole bag of 500 mils. Because you won't think too clearly in these situations. And the results, this is all based on some dog experiments published within the last 10 years in regional anesthesia and pain medicine. And I'm only going to briefly mention this for one slide because I know there's another lecture. No matter how ill your mother has been, no matter how much blood she has lost, remember that even still, deaths from pulmonary embolism are common in obstetrics, and we need thromboprophylaxis. And again, the Royal College of O&G in England are now, because of the tide of obesity, basing the dose of clexane and oxytocin on weight. And many of our mothers are over 90 kilograms of booking, and so the doses go up accordingly. And please bear this in mind in your mothers. In conclusion, your obstetric colleagues should be some of your best friends. Be in regular communication with them. Be prepared. Always be ready. Your labour rooms and your delivery rooms should always be ready for emergencies. No messing, looking for things we at a minimum have twice daily board rounds. I don't know whether you can see this. This is our board in London. If you can see it, on there is lupus, pre-eclampsia, people who don't speak English, people who are epileptic, people who got high BMI. This is an average board in a London hospital. Keep an eye on this board. If you know the problems that are on there, you'll be able to anticipate any outcome. And thank you very much.